So if CAR Ts are for everyone accessible, my sequence ideal will be CAR T first and bispecific second, because this is one and done, single shot treatment, long treatment-free interval, good quality of life, and definitely I think this should be prioritized.
Welcome to EHA Unplugged, the official podcast channel of the European Haematology Association, EHA. I'm Helen Parker, Community Leader, EHA, and today we're joined by Professor Paula Rodriguez-Otero. She is the Consultant Haematologist and Deputy Professor at the University of Navarra, serving as a key member of the Myeloma Unit at the Cancer Center Clínica Universidad de Navarra in Pamplona, Spain. Professor Rodriguez is here to discuss with us today the current immunotherapies used for treating multiple myeloma. Thank you for being with us today.
My pleasure.
First of all, Professor Rodriguez, how would you summarize where immunotherapies fit in today's myeloma treatment landscape?
So, yes, immunotherapies fit all the way from frontline treatment to the management of late stage of the disease. There are different modalities of immunotherapies that we are using. So let's say the easy one, a monoclonal antibodies targeting anti-CD38, and these are now the base of the treatment, particularly in frontline in combination with proteasome inhibitors, immunomodulatory agents, and steroids. So frontline myeloma patients, they are all getting anti-CD38 based therapies. And then later on, when the disease relapses, we can incorporate new modalities of immunotherapy, and there we can have antibody-drug conjugates, for example, belantamab mafodotin, which targets BCMA. We also have bispecific antibodies that can either target BCMA or GPRC5D, and also new targets that are ongoing. And of course, we also have CAR T-cell therapy that is now approved, available for the management of multiple myeloma.
And can you describe how you position BCMA-targeted CAR T cells and bispecific antibodies in relapse refractory myeloma?
Now, multiple myeloma is moving very rapidly. So I think that until, let's say, 2-3 years ago, all these immunotherapies that you are speaking of, so antibody-drug conjugates, bispecific antibodies, CAR Ts were used very late in the treatment journey, so in what we call triple-class exposed patients, so patients that have already failed proteasome inhibitors, immunomodulatory agents, and anti-CD38 monoclonal antibodies. But I think that how the field evolves, now we are using quadruplets frontline. So really the space of BCMA therapies is second-line myeloma, so early-line relapse. So there you can use belantamab combinations. You can use CAR Ts, mostly cilta-cel, which is the CAR T that has the authorization for the use in second line. And very soon we will be able also to use bispecific antibodies in the same setting, second line, early line relapse myeloma. And then depending on patient characteristics, you will use one or the other depending on, patient's fitness, comorbidities, also disease characteristics. And of course, we still have bispecific antibodies that are approved for later line management, triple class exposed patients, and other CAR Ts, for example, such as IDISNA, that is approved a little bit later in the treatment journey. And then, depending on the indication and depending on the patient, we will go for one treatment or the other.
And from the International Myeloma Working Group guidelines, what are the key points on how bispecifics complement or compete with CAR T in practice?
Yeah, I think that we all get this question. No, it's CAR T or bispecifics. No, it's bispecific versus CAR T. I think it's not versus, it's and, because of course, will depend pretty much on the patient. So there is a lot of guidelines, expert consensus recommendations that say that whenever the patient is eligible for CAR T, and if CAR Ts are available, so CAR T should be used first as the first BCMA therapy. Mm-hmm. Because we know that if the patient is exposed to prior BCMA therapy, that has an impact in the outcome of CAR T. But of course, there are patients that may not be eligible for CAR T. There are countries in which CAR Ts are not available. And so bispecifics are a great alternative, showing high responses, durable responses, and long progression-free survival. So the guidelines aim to provide guidance, if I may, for those physicians starting their journey with bispecific antibodies. So they provide guidance on how to manage the typical complications, so cytokine release syndrome, neurological toxicities, infections, which is a big theme or one of the most important adverse events seen, particularly with BCMA bispecific antibodies. So, and this management is key for the outcome, and we have improved a lot. And this also has a great impact in PFS OS. So it's not only efficacy, but the management of the safety is also critical.
And when you have access to both BCMA CAR-T and BCMA bispecifics, what are your main criteria for choosing one over the other first?
Okay, so as of today, the indication is rather different. Second line is mostly CAR-T that is available. Late line is both CAR-T and bispecifics. So assuming that we can get access to everything and we have an ideal patient, ideal for CAR-T and also ideal for bispecific, for me, there are several points that are important. So for CAR-T, first and foremost is good bridging therapy. So bridging therapy is essential for CAR-T efficacy and CAR-T safety. So if you do not have a good option to bridge your patient for CAR-T, the CAR-T eligibility becomes less evident. So that will be one important aspect. Second thing is the kinetics of the disease. So if you have a disease that is rapidly progressing with very aggressive disease, so again, probably this is not a patient that will make it to the infusion because we need to wait for this manufacturing time. So unless you really have an option to bridge that patient that you are convinced the patient will respond, again, this is not probably an ideal patient to go for CAR-T. And then patients with significant comorbidities, again, they are not doing as well. So there is a recent analysis from the real-world data from the US analyzing factors that were associated with non-relapse mortality to CAR-T, which is also a big topic in the field of these novel immunotherapies, and absence to response to bridging therapy, age over 70, were some of the factors that were associated with less good outcomes to CAR-T. So all these factors need to be taken into consideration when making the decision between one or the other.
If cost and logistics were no barrier, how would your ideal sequencing of CAR-T and bispecifics look?
So if CAR-Ts are for everyone accessible, my sequence ideal will be CAR-T first and bispecific second. Because this is one and done, single shot treatment, long treatment-free interval, good quality of life, and definitely I think this should be prioritized.
And what do current data tell us about how prior biospecific therapy affects CAR-T outcomes and the other way around?
Yeah, this is a very important question. And honestly, the data that we have today is still rather limited. Small cohort of patients, very heterogeneous, coming from different backgrounds, different treatments, different doses. So it's not that easy to answer. But we know that, bispecifics are given until there is progression, continuous treatment, targeting constantly the T cell. So we know that at the end of the day, that decreases the T cell repertoire and that induces exhaustion in the T cell compartment. So you don't want to pick T cells that do not have a great repertoire and that are already exhausted to make CAR-Ts. So what we have seen is that when we are doing bispecifics and then CAR-Ts, we get a higher percentage of out-of-specification products for CAR-Ts, and the progression-free survival and the outcome of CAR-T after a patient has been receiving bispecific is inferior. So that is why that sequence is not ideal. And if you, by chance, you have a patient that received bispecific, the recommendation will be to have another line in between, sort of refreshing or resetting the immune system, recovering the T cell compartment, and then try CAR-T later. The other way around, so CAR-T is one and done. So you have then treatment-free interval. And also the proportion of patients presenting with loss of BCMA or mutation of BCMA is much lower after CAR-T treatment as compared to bispecifics. So the chances that your patient will still have BCMA expressed are higher, and then you can rescue either with a BCMA bispecific or also with a bispecific targeting GPRC5D. And that is why also all the expert consensus recommend CAR-T first, because eventually the sequence will be easier if you have a patient first doing CAR-T and then rescue with the bispecific antibody.
In practical terms, how do CRS and neurotoxicity differ from CAR-T and bispecifics?
I think that for me, the main difference is predictability. So with bispecifics, CRS and ICANS are very predictable. You know when it's going to happen in the first step-ups. If the drug is subcutaneously, normally 2 days after the first or the second step-up is if it's IV, 24 hours more or less after the end of infusion. So you know and you can be prepared and you can tell all your teams, okay, the patient was dosed today, CRS will come tomorrow or the day after, depending on the drug that you are using. With CAR-T, that predictability is not there because this is a living drug. So each patient may react, the cells may be different, and also it's less predictable the severity, because with bispecifics, these are mostly low-grade event, generally grade 1, very, very few grade 3s. You can also delay the next dose until the patient recovers completely, whereas for CAR-T, the cells are already in the patient. So for me, that is important to have in mind because treatment of CRS should be aggressive and rapid in all cases, bispecific and CAR-T, but more so in the CAR-T space. So don't hesitate to treat grade 1 CRS and be energetic in treating, because if not, the inflammatory cascade is already established and maybe late. And that is why it's important to have this awareness.
How do you manage infection risks with these therapies, and are you concerned about long-term immune effects?
So this is very important. We know that when patients receive treatment, either CAR-Ts or bispecifics targeting BCMA, they will experience hypogammaglobulinemia, so low immunoglobulin levels. And this is also related to infections, and also because BCMA is expressed in normal B cells and normal plasma cells, they will have this B cell aplasia. And all this, plus the T cell dysfunction, increase the risk of infection. So this is of great importance, and all patients should receive prophylactic therapy with acyclovir to prevent viral infections, with bispecific throughout the treatment. And even if you stop, you should continue months after stopping the treatment. And for CAR-T, is generally 1 year after infusion. All patients should receive prophylaxis against pneumocystis infections with cotrimoxazole or alternatives, again, throughout the treatment, at least 1 year after CAR-T cell infusion. And particularly with BCMA bispecific antibodies, all patients should receive replacement therapy with immunoglobulins to treat the hypogammaglobulinemia as soon as possible. So here the recommendations shift from, okay, at the beginning we said when IgG levels drop below 400, that is when you should start immunoglobulins. Now we know that primary prophylaxis with immunoglobulins, regardless of the IgG levels and regardless of infection complications, is very important to really decrease the incidence of infection. So all patients under BCMA bispecifics should receive immunoglobulin replacement from the beginning of treatment throughout the entire therapy, continuously, every month, to get these IG levels. The higher, the better, and decrease the infection risk. Because normally these patients will have the first episode of infection in the first month, and the first severe episode also very early on. So that is why it's so important to start all these prophylaxis very early on.
How do you adapt your use of CAR-T and bispecifics in frail patients?
There is good evidence, particularly coming from real-world studies and also analysis in the pivotal study showing that we can safely use bispecific antibodies in patients over the age of 70 and also in frail patients. One aspect that I would highlight is that elderly patients have more incidence of ICANS, so of acute neurological complications, and can be more severe. So I would recommend physicians treating these frail or elderly patients to have a comprehensive neurological evaluation baseline so that they will know how to proceed in the event of ICANS and so on. And another important aspect of these frail and elderly or comorbid patients is infection risks. These patients have a much higher risk of dying because of infection complications, and that is why, in all patients it's important, but in this particularly, all prophylaxis starting early with immunoglobulin supplementation is key, and monitoring these patients closely in the hospital eventually or closely in the clinics to prevent early onset of severe infections.
As these agents move earlier, in which situations might they realistically challenge or replace transplant?
So we do not know yet because the trials are ongoing, and there is studies challenging transplant with CAR T-cell therapy, and there are also studies challenging transplant with bispecific antibodies. And honestly, if you ask my opinion, I do believe that in the future, transplant will be replaced. And the reason is that transplant is just a platform to improve the depth of response in myeloma. So it's not specific of the disease. It's just high-dose chemotherapy with a stem cell graft, no? So in myeloma, we know that getting into deep responses is critical for long-term outcomes. And now we have better platforms to achieve these deep and durable responses, such as CAR T-cell therapy or bispecifics that are myeloma-driven drugs. So they are not just myelosuppressive agents that by chance will kill myeloma cells. They are really targeting a clonal myeloma cell. So that is why I believe these drugs will position in frontline and will replace transplant as a better way to achieve deep and durable responses.
How should MRD results influence decisions to continue or stop immunotherapy, especially with long-term bispecific use?
This is a key question that we do not know how to answer today. But with the data that we have now, with bispecifics coming for second-line treatment and being indicated until there is progression, that is not probably feasible from a healthcare perspective, and probably is not also feasible from a patient perspective, because that means that these drugs will be, requiring continuous administration in the hospital. And we know, and there was data presented at last ASH meeting with the teclistamab in combination with daratumumab, there is a flattening of the PFS curve, very few events beyond 1 year, 6 months. So maybe some of these patients will be in remission, sustain MRD negativity for, 2-3 years. They may be eventually cured, and maybe the treatment can be stopped, because indeed the treatment is targeting BCMA that is no longer there, because BCMA is gone, because no plasma cells are left, no? So I think that this is the next generation of trials that we need to do to really address how long the treatment should be maintained until we get into deep responses, how much sustained MRD negativity we need to be able to stop treatment in all patients.
How do you see new targets like GPRC5D and FCRH5 fitting in mainly as post-BCMA salvage or also earlier in the disease course?
So that is how the field is moving and how these drugs are being developed. I think that all of us now are seeing these drugs as post-BCMA targets. So you go first with BCMA and then you go either for GPRC5D or FCRH5. But honestly, there is no biological reason to say this should be done after the other. It can be used before. But I think that, GPRC5D has some own toxicities, oral toxicities, skin toxicities, nail toxicities that, although not severe, they have an impact in patient quality of life. So that is also why we position this maybe later on after BCMA therapies. FCRH5 is better tolerated as compared to GPRC5D in that regards. but the evidence that we have is much less. So with FcRH5 bispecific, there are now studies ongoing in early line relapse in combination with pomalidomide that we need to wait for the results, but overall, it's also a good alternative. And assuming that BCMA therapies will come into the front line, those will be great combinations to have as part of the second line treatment.
Over the next 5 to 10 years, what are the most important research questions and controversies in myeloma immunotherapy?
For me, today, I don't know in 10 years, but one of the biggest questions that we have is how to decide between bispecifics and CAR-T. So how to know which patient will perform better with each therapy, because we will have all available, hopefully, in the same setting. So we will need to make this decision. Okay, you look good for CAR-T, let's go for CAR-T, or you look better for bispecific. So I think this is one of the biggest challenges that we will be facing. Second big challenge is fixed duration treatment with bispecifics, to your earlier question. So how long is long enough so we can just stop? And I think the third is really how can we deliver these drugs safely? Because even though we have improved a lot, non-relapse mortality with these modalities is still relevant, around 7% or so. So we need to do better. So I would say these are the three main challenges that we will face.
And if you want our audience to remember one thing from this podcast, what would it be?
Exciting times in myeloma, great drugs available, inducing deep and durable responses, with safety profile that is manageable, but that we need to learn how to manage. And that all of us, we need to start using these drugs because this will be the future of the management of multiple myeloma.
So, thank you very much for being with us, Professor Rodriguez.
My pleasure. Thank you.
And thank you to the audience for listening, and thank you to BMS for supporting this episode with an unrestricted educational grant. If you enjoyed the episode, please like it and subscribe for our channel, and stay tuned for more episodes of EHA Unplugged.